to start with to begin the day. First of all, conference presentations are available at the Norton Healthcare, actually at nortoncme.com. You select the conference details and presentations, and then this event. And also the agenda and evaluation links can be found here as well. Evaluations, you will complete an online survey. The link is located on the nortoncme.com site in the chat notes. And if you're registered for the symposium, an email link will be sent following the program. We're also providing American Board of Pediatrics MOC credits. Physicians certified by the American Board of Pediatrics can receive this credit by completing the MOC online survey. There are two ways for you to communicate with us during the conference. First of all, via question and answer. There's a box that in this space, you can submit any questions that you have for the speakers throughout the day. Following each talk, we will have a few minutes, usually probably 3 to 5 minutes for Q&A, and we'll pull the questions from here. In the chat box section, it's here if you have any questions for the CME team. Logistical questions or comments, please enter those in this space. Also, if you see a colleague that is attending this meeting, you can also privately chat with them and virtually network. Today, our keynote speaker is Dr. Sarah Goza. She is the current president of the American Academy of Pediatrics and will also be available to chat with you throughout the day. Now, just to give notice, that's not a private chat that will be seen by all. If you'd like to connect with her and communicate, you can send a direct chat message to her in Zoom. In the exhibitor hall, if you're interested in speaking with any of the program exhibitors, simply click on the link that was emailed to you, but there will be an updated email sent to you shortly, as we've had an extra exhibitor added as of last evening. So look at the email that will be sent to you shortly, so you can click on those links if you'd like to connect with our exhibitors in the exhibitor hall, or on the nortoncme.com symposium details page. So participation is optional, but you can speak to as many of those folks as you're interested in. You can also, just in closing, you will disconnect from the main meeting webinar and rejoin when the lunch break is over. So off to our first speaker. At this time, I'm honored to welcome our first speaker, Dr. Kent Walker. Dr. Walker is a pediatric orthopedic surgeon with Norton Children's Orthopedics of Louisville and affiliated with the University of Louisville School of Medicine. He obtained his medical degree from DeBusk College of Osteopathic Medicine, Harrogate, Tennessee. He attended residency at Wellmont Holston Valley Medical Center at Kingsport, Tennessee, and completed a pediatric orthopedic fellowship at the Campbell Clinic in Memphis, Tennessee. Dr. Walker enjoys treating all orthopedic conditions, including fractures, sports, injuries, foot and ankle problems, and with special interest in pediatric spine conditions like scoliosis and neuromuscular spine conditions. So Dr. Walker, welcome, and looking forward to hearing from you.
Thank you. Thank you for having me. This is the first time I've spoken to this many people and actually didn't see an audience. So I'm excited to do this, although I am going to miss not talking at the Galt House. So today we're going to talk about scoliosis. We're going to talk about the diagnosis and treatment. But since scoliosis is such a wide variety, we're going to talk about specifically adolescent idiopathic scoliosis. I do work for Norton Children's Orthopedics of Louisville. Most of you are familiar as COOL for our group. So what is scoliosis? Scoliosis is defined by the Scoliosis Research Society as any curve that's greater than 10 degrees. If they have a curve, but that curve is less than 10 degrees, then that's just considered spinal asymmetry. And the way we get that, the degree of curvature is by taking the cranial invertebra, the caudal invertebra, and you make a line that's perpendicular to those end plates. And then where those two lines cross, that curve or that angle is what is measured as the Cobb angle. Luckily, we have nice computers that can do that for us, makes it a lot easier. And so adolescent idiopathic scoliosis is scoliosis in a child or adolescent that is 10 to 18 years of age and the curve's greater than 10 degrees. The female to male ratio is 10 to 1. It's usually going to be a right thoracic curvature. And to have true adolescent idiopathic scoliosis, it needs to meet 3 different criteria. So that's the lateral curvature, as you can see to the right. It's rotation of the vertebral body. So I tell all the patients, in their family, this is a three-dimensional problem. That's why you see the rib hump. That's why you may see the lumbar asymmetry. And then also you'll have hypokyphosis through the thoracic spine. So if you just looked at their back, you would think that they had a kyphotic deformity in the thoracic spine, but actually when we get CT scans and we can look at it closely, they're actually very straight through this area. And if they don't meet those three criteria, then it's possible that they don't have adolescent idiopathic scoliosis, and they may have a secondary cause of scoliosis. And so the pathophysiology, right now, it's considered idiopathic. It's really a multifactorial cause. There's usually a positive family history. There's some question of whether a melatonin or a vitamin D deficiency may have some component to scoliosis. But what I tell everybody is right now it's considered idiopathic, but I'm sure in 40 or 50 years, they're going to look back at us and then they're going to be like, why did they think this was idiopathic? Because by then they're probably going to figure out what the genetic mutation is that causes this. Because as you can see, it's usually a young female who's thin and has these same characteristics. And so there's a few myths and facts that we should talk about. First of all, back pain is not an indicator of scoliosis. Backpacks cannot cause scoliosis. Bad bedding does not cause scoliosis, and bad posture does not cause scoliosis. In fact, adolescent idiopathic scoliosis has few symptoms. If they have back pain, then you probably want to look for something else that's going on. 30% usually have a family history. It affects about 2 to 3% of the population. And then once again, the vertebral changes are multifactorial. So when they come to your office, what are you going to see? What are you going to look for? So usually the first thing you're going to notice is unequal shoulder height, where one shoulder is higher than another. And then sometimes you may notice that one side of the pelvis is higher than another, but you got to be careful with the pelvis height because sometimes it can look like scoliosis, but in reality, it's a leg length discrepancy. So if you have an x-ray and you see a very significant difference in their pelvis heights, but their curvature is not that big, then you probably need to look at the length of their legs as well. But also you want to have them do an Adams Ford bending test, because true adolescent idiopathic scoliosis is going to have a rotational deformity. So if they have a shoulder that's uneven or a pelvis height that's unequal, and then you have them bend forward, but you don't see any asymmetry, then no, number one, it's either not adolescent idiopathic scoliosis, it may be some type of other scoliosis, or it may not be scoliosis at all. You want to look for a truncal shift, and that's just where their pelvis seems shifted towards one side. One of the things to look for would be a cafe au lait spot, because if someone has scoliosis and they have cafe au lait spots, then you want to be worried about neurofibromatosis. If they have cavo-varus feet and spinal and scoliosis, then you want to look for a neural axis abnormality like a tethered cord, a Syrinx-Chiari malformation. And you always want to check abdominal reflexes. If their abdominal reflexes are normal, then there's usually nothing else going on. But if they have abnormal abdominal reflexes, then you probably want to investigate a little further. And I think a great tool is the scoliometer. It's probably not as used as much as it used to be used, but I think it's very good at determining true scoliosis. If it's at least 7 degrees, then your curve is probably at least 20 degrees. So when you see these patients, the imaging that you want to get is going to be a PA and a lateral standing x-ray. And as you can see to the right here, that's the hypokyphosis that I was talking about, how it's very straight through the thoracic spine. But your true scoliosis is going to have your right thoracic curve, your hypokyphosis, and the rotation, which you can see the rotation best in the lumbar spine on this x-ray. And you can see on the PA view, you can see that the spinous process is closer to the pedicle on that part of the spine, as opposed to it should be right in the middle of the vertebral body. And this is the same x-ray you're going to use for your Cobb angle. And it's also important that these x-rays, it's the full length of the spine, because you want to be able to tell their coronal balance and their sagittal balance. So on the PA, you look at their coronal balance and you can see, is their head centered over their pelvis, or are they so trunk shifted that it's actually throwing off their alignment? And sagittal balance, I think, is very important. That's where you draw a line through the posterior superior corner of the sacrum, and that line, if going straight up, should go through C7, or excuse me, yes, through C7, and that tells you how well balanced they are. And I think a lot of these kids with scoliosis, their sagittal balance is off. And I do think that if you do surgery and you don't correct it, that does lead to an increased risk of back pain later. So I think that's something very important that was probably ignored for many years that we are more in tune to now. And then the apical vertebra, that just tells you where the main deformity of the curvature is. And so when you want to get an MRI, so this has always been controversial across the country, but in my training, anyone who had surgery had an MRI. And I think in the adult population, I would say that's probably common as well. But historically, if there was a left-sided thoracic curvature, if they had pain, abnormal curve pattern, abnormal abdominal reflexes, rapid progression, excessive kyphosis, or foot deformities, those were all reasons to get an MRI. And as you can see on this MRI, you want it to be from the posterior fossa all the way to the sacrum, because they could have a tethered cord, which could be down in the lumbar spine. They could have a Chiari malformation, which is up at the where the cerebellum is going to be herniated, or they could have a syrinx. There's multiple other things that they could have, but that's why you would get the MRI. And this is what the parents and the family always want to know. My child has scoliosis. What does that mean? What's the long-term outlook of that? And so I explained, if you have scoliosis, you are at an increased risk of having back pain once you're finished growing and for the rest of your life. It's about 61% compared to 35% of the general population, but you're not at any higher risk of disability. You're not at any higher risk of having lost time from work. You're not at any higher risk of having depression, and you're not at a higher risk of dying at an earlier age. But where it does get important is if the curve gets to 90 degrees, it really starts to cause problems on your heart. And if the curve gets to 60 to 70 degrees, then it starts to cause problems on your lungs. And so curves that are greater than 50 degrees when you're finished growing, we know that those curves are going to continue to progress roughly 1 to 2 degrees per year. And curves in the lumbar spine greater than 40 degrees will continue to progress 1 to 2 degrees per year. And so that's why the cutoff for surgery is about 45 degrees, because we know if it continues to progress, it will cause issues later. So treatment options, if it's 10 to 25 degrees and they're still growing, I think that's the most important thing, that they're still growing, then you observe it. If it's less than 30 degrees when they're finished growing, then the risk of progression is less than 1%. The easiest way to determine how much growth they have left is called the Risser sign, and that's where you can see how much of the iliac apophysis has closed, and that's what this picture to the right is. The more accurate way is a Sanders classification, which is a PA of the left hand. And if someone is on the fence, I'll get a Sanders classification, because you don't want to not brace someone that should be braced, or you don't want to stop bracing too soon, because the Risser sign is a 3 or a 4, but their Sanders does not correlate with that. So if it's 25 to 45 degrees and they're still growing, then that's when you would brace them with a TLSO brace, or there's a Boston 3D brace, there's a Rigo Chanel brace. So there's multiple braces out there now, but the standard brace is the TLSO brace. And the most important thing to tell the family and the patient is, it's not to stop the progression. It's not to make the curve better. It's to stop the progression of the curve. Nothing's really going to make the curve better. And then there was a study that I'll talk about in a second, but it recommended 16 to 18 hours a day of brace wear. And now there's also Schroth physical therapy, which is an adjunct, which is very helpful, because it helps work on the specific muscles that are affected in scoliosis. And I think a lot of the patients that go and do Schroth physical therapy are more likely to wear the brace. And so I think it's very helpful as it becomes a symbiotic relationship. And so there was a study called the BRACE study. This is an orthopedic study that was published in the New England Journal of Medicine, which is not something that orthopedics do often. We have multiple other journals that we can publish in, but we felt this one was so important that they wanted all specialties to be aware of this. But what they did is they put heat sensors in the brace, and they found out exactly how long a patient wear the brace and how effective it was. And you can see at this graph that, anywhere between 13 to 18 hours. But really, if you look at, the numbers, it was really 16 to 18 hours, put you at a 90% success rate of the curve not progressing. And so that's what I tell my patients, most of them are teenagers, and say, hey, I want you to wear this brace 16 hours a day. And I tell you 16 hours a day because I think you're old enough to understand that. I don't tell you 16 hours a day because I want you to wear it, 8 hours a day. And so I like to show them this picture here. We were walking the other day, and this is what I tell kids, this is what your spine looks like in the brace, and this is what your spine looks like not in the brace. And so a lot of it goes back to common sense. If there's 24 hours in the day, and you wear the brace for 8 hours and you don't wear it for 16 hours, then your back's probably going to look like what it looks like on the right. But if you wear it for 16 hours and you don't wear it for 8 hours, then your spine's probably going to look like what it looks like on the left. And so, I try and put the ball in their court a little bit and let them know, this is the decision that you have to make. And sometimes it's tough because as a teenager, you don't get to make a lot of decisions. And this is one of their first decisions that they get to make. And so I think this really needs a concerted team effort from all of us, because hopefully we can prevent a big surgery. And speaking of surgery, historically, you could do a posterior spinal fusion, which is all from the back. You could do an anterior spinal fusion, which is from the front, or you could do a combined posterior and anterior. And I would say that the majority of surgery is now mainly done from the posterior spine. Because we have better technology now and we're better able to control the curves all from the back. But if the curve is greater than 45 degrees, then we recommend surgery. And if it's greater than 4 degrees in the lumbar spine, then we usually recommend surgery just because we know those are going to progress. And so one of the things I talk to the families about is how we do the surgery. So Dr. Meyer and I, he's one of my partners. We actually double scrub all of our spines for a few reasons. Number one, it's faster, it's less blood loss. But also if someone says spine surgery is not stressful, then they're probably not taking it serious enough. We enjoy it and we do a lot of it, but every case needs to be taken very seriously. And so this is kind of what I showed them. A picture on the left is probably how someone who trained, 20 years ago or so may have learned how to do scoliosis surgery. And then the picture on the right is a picture of how we do it now. And the difference here is we're using pedicle screws. And so the spine is broken up into 3 columns, a posterior, middle, and an anterior. And if you use pedicle screws, you're grabbing all 3 columns of the spine. But if you use the picture on the left, which is mainly hooks, you can only grab the back of the spine. And so if you're only grabbing 1/3 of the spine, you're not going to be able to get the same correction. As you can see, if you look at the ribs on the left compared to the right, the ribs are not straight on the left, but on the right, they're equal. And that's how you are going to be able to derotate the spine and affect that rib hump. Now, you're not going to be able to get it down to 0, but you're going to be able to make it look much better. And also, if you're using pedicle screws, you can address the sagittal balance, like I was talking about on the lateral x-ray. So on this AP or PA x-ray, you should not have a curvature, but on the lateral x-ray, you should have some type of curvature to correct your sagittal balance. We use something called cell saver. That's where we collect the patient's own blood and we give it back at the end of the case, and that decreases the risk of needing a transfusion. And then we also use something called a bone scalpel to help loosen up the spine, which is a lot less invasive than using some other osteotomes. But once again, I always tell the family, the goal is not to straighten the spine. The goal is to fuse the spine so it doesn't get worse. But just by using this technique, it ends up straightening the spine very well. And then anytime you want to talk about surgery, you want to make sure you're going to discuss complications. I tell the people there is a risk of paralysis. It's about 1 in 1,000. And the risk of neurologic injury is about less than 1%. Pseudoarthrosis is where the spine doesn't actually fuse and then the hardware can start to break. That's not as common in adolescent idiopathic scoliosis, but it's still something you must talk about. Infection is around 1%. They'll present with late pain. Unlike a total knee or total hip, you can actually leave this hardware in if you catch it and treat it appropriately. And then flat back syndrome, this was something that when you weren't using pedicle screws, what would happen is you would straighten the spine on that lateral x-ray and you would not correct their sagittal balance, which is not as big of a deal with pedicle screws. And another thing that goes along with that is called the crankshaft phenomenon. So before, when they would use hooks, it would fuse the posterior part of the spine, but it allowed the anterior part of the spine to continue to grow. But it couldn't grow up because it was tethered, so it would have to grow around, and that's how you would get your crankshaft phenomenon. And then for a lot of you patients, or a lot of you physicians that treat scoliosis patients, SMA syndrome is something to look for after surgery. If they have big correction and they start having nausea and vomiting afterwards, then that needs to be treated with an NG tube and IV fluids because they could actually have kinked the SMA. And so this, when I started, we brought a new pain protocol to Louisville. And historically, this was how you would do the surgery. And then also, the length of stay would be roughly 5 to 7 days. The patient would go to the ICU. They would only get therapy once a day. They would have an A-line, so they would have to go to the ICU. And then they would need a brace after surgery. Well, our new pain protocol that we started in 2018, it's a multimodal pain protocol. There's no ICU stay. We get them up on the side of the bed the day of surgery. The first day after surgery, we're having them walk in the hallway. They're working with therapy twice a day, and their length of stay is 3 to 4 days. And so this was developed at CHOP, the Children's Hospital of Philadelphia, which is usually the #1 hospital in the country each year. And it was developed in 2014, and it was implemented at the Campbell Clinic in 2016, which is where I did my fellowship. And then I brought it here in 2018. And now our length of stay is 3 to 4 days. And I would tell you that our length of stay is really the rate limiting step is now if they have a bowel movement and it's not really pain control. And the idea is that it's less narcotics, but better pain control. So the goals of this protocol is to optimize pain control and decrease IV opioid side effects. So constipation, nausea is a real thing, and it can really decrease your mobility in the hospital. But actually, we've also seen that it helps patient comfort and patient satisfaction. And so who are candidates? So anyone who has adolescent idiopathic scoliosis is going to be a candidate. This was a patient of mine who had achondroplasia. We had to remove 2 of her vertebrae. She would not be a candidate for this because she had so much blood loss. She did need to go to the ICU for a little bit more intensive monitoring. But the majority of our AIS patients are going to be candidates for this. And we get them started early, at their pre-admission testing. Our nurse practitioner meets with them and they go over the goals of this and what to expect after surgery. And I think the most important thing to tell these children is that, it's a painful surgery and it's going to hurt. And I always tell them, the day of surgery, you don't remember much. The day after surgery hurts a little bit, but the second day after surgery, which, if surgery was on a Monday, on Wednesday, I explained that's usually the most sore you're going to be. And it's just like working out. If you get a really hard workout on Monday, you may be a little sore Tuesday, but then come Wednesday, you're going to be very sore. And then the day of surgery, before surgery, we give them Tylenol, Valium, gabapentin, and then also anesthesia. I started to add methadone, which helps with the pain control during surgery. And then after surgery, we give them a PCA. We have them go to the floor, not the ICU, because you can get early mobilization on the floor, which you're not going to get in the ICU. We start them on gabapentin and Valium. We start them on a clear liquid diet. An incentive spirometer is great. Patients, they can really open up their lungs, and it seems to help so much if they actually use it. And we get them on an H2 blocker and a PPI because we don't want them to have reflux. We don't want them to have nausea. And then we start them on Colace and Miralax right away. And then the first day after surgery, we will use IV Toradol. It will get rid of the PCA, and we'll add IV Dilaudid as needed. And then we get rid of the Foley. And at this time, we schedule our Tylenol, and we have oxycodone. We continue the gabapentin. We continue Valium. We have them walk with therapy. They have a regular diet. We continue the bowel regimen, and then we continue the incentive spirometer. And post-op day 2, we continue everything that we've done, but we kind of ramp it up a little bit. We start stairs with physical therapy. We'll add to the bowel regimen if needed. And post-op day 2, sometimes post-op day 3, just depending on how their pain is, we'll go ahead and get standing x-rays. And as you can see, all these pictures that I've been showing, these are all patients that Dr. Meyer and I have done. And I think you can see that, we do a fairly good job with correction. And then on post-op day 2, we start talking about discharge with the family. So, they're not ready to go home, but we start, our nurse practitioner talks to them, make sure that they have everything that they're going to need to go home, that they feel comfortable to go home. We actually have the family start walking with the patient in therapy so they feel more comfortable with the patient going home. And I think, it's quite amazing how well these patients do. And then on post-op day 3, we stop the Toradol. Sometimes that's post-op day 2, just depending on when the Toradol was started. We only do 5 doses because we don't want to affect the kidneys. When they're with therapy, they have to be able to walk 150 feet, and they have to do 1 flight of stairs without help. And then to go home, they have to be able to be tolerating medicines by mouth without any IV breakthrough medicines. They must be tolerating their diet, and they must have a bowel movement. And like I said, sometimes having a bowel movement may actually be the rate limiting step for when they can and cannot go home. And then we have a close follow-up. We have the nurse practitioner call them a few days after surgery or after discharge. We put a waterproof dressing on before they leave. That way they can shower. I'll let them shower for the first 2 weeks with the waterproof dressing on. I don't want them to shower I don't want the wound to get wet for at least 2 weeks. And I don't want them to soak in a bathtub or get in a pool for a month. When they follow up at the 4-week mark, we'll get repeat x-rays. And a lot of times what we'll notice is that they'll have some muscle spasms, and explain to them that you'll continue to see improvement in the correction all the way up to a year as they start to normalize and rebalance after surgery. And then they're usually out of school for 6 weeks, but when they come back at the 4-week mark, they're usually asking if they can go back sooner. I usually allow that. And there's one other thing I wanted to talk about, and there's some exciting future treatments in scoliosis. This was the only one that's FDA approved at the moment, so this will be the only one I'll talk about. But Dr. Meyer and I are interested in this as well as some of the other things that are coming out. But this is called vertebral body tethering, and this is for kids who still have growth left. They're usually around a Risser 1. And their curve is usually between 35 and 55 degrees, and it's a flexible curve. And what you do is you actually go in through the thoracic cavity thoracoscopically, and you put these screws in the vertebral body from medial to lateral. Once you do that, you can go in and you can tighten these screws with what looks like a Chinese finger trap almost, and you're able to get good correction. And the way this works is you are actually tethering the side that has grown too fast, and they're going to allow the side that has grown too slow to catch back up. And I think it's a great option because number one, it's fusionless, and so you don't have that big surgery, but also it allows the option to, if you're not fusing the spine, you're still going to have better motion with that. I would say that it's still early, but they have shown good results with this, and it's something that we're definitely interested in. The only caveat of that is that you do have to go through the thoracic cavity, and that they would have to have a chest tube. So the length of stay is probably not any different, but the invasiveness of the surgery is going to be slightly less. And like I said, there's a couple other things we're interested in. And what we want to do here in Louisville is we want to be able to offer any treatment in Louisville that they can offer anywhere else. We just want the pediatricians and the families to know they don't have to go to Cincinnati or some of these other places to get top of the line scoliosis care. And that's the end of my slide. Since I'm not there in person, this is my email address. If anybody has any questions they'd like to ask offline, please jot that down, and I'd be happy to answer any of your questions.
All right, thank you, Dr. Walker. We have one question from Dr. Ellsberg, and the question is as follows: what is the advantage of having surgery as an adolescent versus waiting until the curve really reaches the problematic level?
That's a good question. So it's a much easier surgery when you're younger. The soft tissues aren't as scarred in, and so it's a lot easier to get correction. You don't have to do as many osteotomies where you actually cut the bone, and they recover much quicker.
All right, thank you. One other question from George Rogers. Do you have data that the gabapentin is helpful?
So when CHOP did their study, that was included in it, and this actually came from is from the total joint literature, and it was added as one of the medicines that was helpful. Now, I don't know if they have repeated that study to take the gabapentin out, but it was just in the initial study.
All right, thank you. We'll take one more question. Dr. Laura Jacks asked the question, do the tether anchors you mentioned have to be removed?
No, unless they break, they do not.
Okay. Well, I believe we're at time, so I want to thank Dr. Walker for the presentation this morning, kicking us off for our first all-day virtual symposium, and appreciate the questions and engagement from the audience as well. So let's move to our next speaker. Thank